Okay, it's 12:30. Welcome everybody to this session of the 2024 Culture of Data Conference. Thank you all for joining us. My name is Taylor Bostic. I use she, her pronouns. I'll be moderating this session. We also have Rachel Massman, she, her also, who's managing the Zoom for us and making sure our tech is running smoothly. So as of right now, everybody is muted, but if you have any questions during our Q&A session at the end of our presentation, please feel free to unmute yourself, or you can also drop questions in the chat. Um, Let me think. If you're comfortable with doing so, please add your pronouns to your Zoom name, and you can do so by clicking on the three dots of your video square and selecting Rename. So we have one presentation during this session. They will be presenting for approximately 25 minutes, and then we'll have about a 10-minute session for Q&A at the end. I'm really quite excited to see this presentation and learn more about how telehealth programs can be more equitable in our state and potentially even nationally. So at this time, I'll turn it over to Carrie Frank and Claire Leather to present Understanding Telehealth Equity in Colorado.
Well, thank you so much. We're super excited to be here. What I want to make sure to mention at the beginning is that we kind of expanded this based on our original abstract submission. We're going to be talking about telehealth equity, but we're also talking about health equity in general, because we have two really robust and exciting analyses that are out there ready to be used by public health folks. And so we wanted to make sure we mention both of those. As Taylor mentioned, my name is Carrie Frank, and I'm the Vice President of Communication and Marketing at CIVHC, which is the Center for Improving Value in Healthcare. And I'm joined today by my colleague, Claire Leather, who runs all of our public reporting. She's our public reporting program manager. I'm super excited to be presenting with her today. So really quickly, I just wanted to let you know a little bit more about CIVHC in case you've never heard of us. We are a nonprofit organization that equips partners and communities in Colorado and across the nation with resources, services, and unbiased data, which we're going to be talking a lot about the data part of what we do. Everything we do is to improve health and healthcare, with the ultimate vision that everyone has the opportunity to be healthy and has access to equitable, affordable, high-quality healthcare. We pride ourselves on being independent and objective and service-oriented. And speaking of service, we serve a wide array of folks in the healthcare ecosystem, all with consumers in the middle, but we support clinicians, hospitals, government agencies, public health entities like those of you on the phone here today. We call out these people change agents, because they're really doing the work on the ground to improve healthcare. And how we serve is through public data and non-public data. We'll be talking about our public data a lot in this presentation. We have many resources online from the Colorado All-Payer Claims Database, which I'll talk about a little bit more in the next slide. But a lot of information publicly available at civhc.org. And then we also offer non-public data as well. We also provide evaluation and research services and do a lot of community engagement and program-specific work in aging, palliative care, and advanced care planning. So in the APCD, which is a lot of the data that we're going to talk to you about today, the All-Payer Claims Database, we collect claims on a monthly basis. It's a legislatively mandated database that went into legislation in 2010. It has over 1 billion claims. We get those claims on a monthly basis from 48 commercial payers, so it's private insurers, as well as Medicaid and Medicare Advantage and fee-for-service. It is very robust, represents over 70% of the covered lives in Colorado, which is over 5.5 million lives. We don't collect federal programs, so we will not have information in the database on VA, TRICARE, Indian Health Services at this time. They're not set up to submit to an APCD, unfortunately, and then anything that doesn't get paid for in a claim. So we don't get anything that was paid out of pocket or any uninsured claims. And there is a federal legislation or federal ruling from the Supreme Court that doesn't allow an APCD to mandate self-insured employers that are ERISA-based. So we don't have the majority of those in our database, but they can voluntarily submit. So we are collecting some of those. So what we're going to be talking about today is health equity. Why does it matter? I think this audience probably knows a lot about social determinants of health, but up to 80% of a person's health is related to social factors that are out of their control. And we know that that's been proven. And so we want to understand how social factors are impacting folks' health and their ability to stay healthy. So the first analysis we're going to talk about is the health equity analysis. It's more broad than our telehealth analysis, which Claire is going to go over. But this looks at cost, utilization of services, and access to care. And it shows those factors related to social factors and the impact that potentially the social factors could have on the use of healthcare services and the cost of healthcare care services. And we developed this to support policymakers, public health professionals, communities, and others that are looking for ways to identify and address health inequity. So the social factors that we used, we geocoded the database, which is just a fancy way to say that we assigned a latitude and longitude address point for each person and each provider in the database. So we're able to look at census tract level information. So we pulled in census tract from the US Census American Community Survey information and the CDC I always stumbled over this, Social Vulnerability Index. It's a mouthful. And we married those with some of the information in the claims data that we've already produced in our community dashboard. So looking at access to care, quality measures, cost information, and then some utilization. I'll go over these a little bit more. You'll see them when I'm demoing the analysis, which is what I'm going to do right now. Because I think more excitingly is for you to actually see it in action and see how you might potentially use this. So where we are, just so you know how to get here, this is our civic.org website. If you go to get data, public data, and focus areas, you are here on this health equity analysis page. Feel free to go there at any point in time. We have a KPI. I have to give it a plug that the more people that go to our public analysis, the better we're doing our job. We want folks to be utilizing this information. We have data highlights here, which we're going to go over. This is a full infographic. If you click on it, that you can download. We've done additional webinars on it. You also have a how to use the report button and understanding the results, which I'm going to talk to you about, but you can always reference that later. Considerations are more like what's in the data, which we just kind of discussed, what's in, what's out. So this is the health equity analysis. Hopefully this is big enough for you, but I wanted to kind of give you a lay of the land. I'm going to go back to the beginning here. This is already set for something I'm going to show you here in a minute. So what you have is measure definitions. So if you're ever not sure what you're looking at, you can click on that button. But first you'll want to select the social determinant of health factor that you're interested in. Right now we're looking at the percent below the poverty line, but we have those education, percent without high school diploma, percent unemployed, and that housing and transportation is the composite measure of the crowded housing and or without a vehicle, and race, ethnicity, language is people of color and or limited English. So I'm going to leave it for now on the percent below poverty. And then you have the ability to look at this healthcare measure of interest. So we have the two access to care measures, which are lack of access to care in either children and adolescents or in adults. We have a quality measure that is no follow-up after an ED visit for mental health within 30 days. And then we have cost measures, which is cost of care per person per year, and then two, utilization, all ED visits, and then potentially preventable. I'm going to click on potentially preventable because those are the ones that we don't want to have happen. If you're familiar with Tableau, you often get this strange warning box. We don't know why it happens. We've been trying to figure it out. Just click on it, ignore it. It doesn't, pretend it doesn't exist. So what you get here then is a lay of the land across all of Colorado, because we're going to keep it on Colorado for now. This is telling us the relationship between income and potentially preventable ED visits. And the most important thing to look at is this R value right here, which is the Pearson's correlation coefficient, if you are familiar with correlation measures. So right now, we are getting a 0.57. And I don't know if you're like me, I need to look at the scale every single time. But a 0.57, if you look at the R value scale down below, means that we're within 0.4 and 0.69, which indicates there's a very strong relationship between these two factors that we just selected. So as income level is lower, in this case, the percent of people below poverty, as the income level is lower, we tend to see a correlation in higher use of potentially preventable ED visits. But each one of these little dots here is a neighborhood. So not all neighborhoods are created equal. And you can see down here at the bottom, this is in Broomfield. They have the lowest percent of folks in poverty, 0% actually, and they have very low potentially preventable EDs, 46 out of 1,000. Whereas up here, we can look at Pueblo County, which is showing us that this particular area in Pueblo has 91% of the folks in below the poverty line, and they have 355 per thousand ED visits that are potentially preventable. So those are the ones we would want to avoid. So if you want to dig deeper into, hey, what's going on in Pueblo County, you can come over here, select Pueblo, and then it will isolate all of the census tracts within Pueblo. So this legend here, where we have low use of ED visits and lower income levels below, and up in the red is higher ED use and higher percentages of income levels. But you can see in Pueblo County, it's different, right? You have some green here right next to a lot of the red. And so you have some neighborhoods that are just really close and adjacent. They're having very different health access outcomes. So you can zoom in on these so that you can kind of play around with it, see which places in Pueblo. But going back up here, now we've just isolated to Pueblo, and you can see that that R value is even higher in Pueblo County. So that is 0.75, which is a very strong relationship between these measures. That is a very high level down and dirty of how you would use this. One other thing to point out is if you click on one of these counties, let's just choose this neighborhood here, you can also see the breakdown of the race and ethnicity in this county. And this is comparing Pueblo in general to this county. So even within this Pueblo County, you have different makeups of race and ethnicity. This one that we're clicking on has a higher percentage of Hispanics in that particular community compared to all of Pueblo. And when we were at the higher level, Colorado, you can also see how Colorado numbers compare. So very low percentage in general across all of Colorado. So that's a quick snapshot of how you would use the information. And I'm going to go back to our presentation because what we've done then is look at this analysis a little deeper and see what we were finding at the statewide level. Interesting findings across that preventable emergency department visits. What we found is every single factor that we looked at, income, education, didn't matter what we looked at, all of them were strongly related to higher preventable ED visits. They were all also very strongly related to adults not receiving preventive care. So as people had lower income or they didn't have access to transportation, adults were tending not to go get preventive care. However, what we did see, which was interesting, that the social factors did not have an impact on children and adolescents receiving preventive care. So that could be for a number of reasons. We have a very strong Medicaid system. So low-income children are often covered by healthcare services through Medicaid and other sources. And I think adults prioritize, their kids getting care over themselves, especially if they only have time to get their kids preventive visit. They're probably going to do that so that they can enroll in school and do all of the things and keep their children healthy. We didn't see an impact on cost of healthcare services across any of those measures. And then we just saw a moderate to weak relationship between the follow-up care after an ED visit for mental health services. So this is the breakdown of all of the different social factors. You can see this green here is the children and adolescents, which if you look at the table up here, that's the weak relationship, nothing there. But here's the potentially preventable ED visits, very strong relationship between all of these social factors up at the top. So I'm not going to go into detail about all of the other findings, but that if you go to that page of our website, you can look at the entire infographic, which shows rural versus urban insights, and then has some highlights of close neighborhoods within Denver County, and the impact that that has on ED for potentially preventable, and then that adult access preventive care as well. So I want to make sure that we have time for our telehealth, which is what you probably came here for. So I'm going to go ahead and turn it over to my colleague, Claire.
Thanks so much, Carrie. Appreciate it. Yep, I'm here to talk about the telehealth equity analysis. Before I want to jump into the report, I do want to share that the impetus for this particular analysis was CIVHC's longstanding partnership with the Office of eHealth Innovation out of the Lieutenant Governor's Office. They're doing a lot of work and have a lot of initiatives around improving equity and access to telehealth. So this report and this analysis was created in collaboration with them. Very much so. So the goal of this report is to look at the relationship between social factors in the US Census data and the use of telehealth visits and in-person visits that could have been delivered via telehealth using information from the Colorado APCD. So this data has a plethora of use cases, understanding how telehealth and in-person visits differ across the state and by county and by neighborhood. You can investigate which social factors have a relationship to high or low telehealth, in-person telehealth use or in-person services use in your community. You can also develop programs and initiatives to support increased access to telehealth or in-person services, specifically addressing social factors impacting a particular community. So a robust data set with a plethora of use cases. So here we're going to talk about what's going on in the actual report. So the social factors that we determined were important to include. So again, in collaboration with OeHI, we pulled in the percent of people of color. We looked into veterans and limited English. We also looked at disability. We looked at unemployment and without a high school diploma. We also included households without internet, computer, or smartphone. And just to note that the Colorado APCD, as Carrie mentioned, does not include the VA claims data. And then next slide. For the health measures pulled from the APCD, we looked at telehealth utilization as defined as a number of visits for any reason, any diagnosis recorded in a claim as a telehealth visit. And the rate is visits per 1,000 people in the Colorado APCD. In-person utilization is defined very similarly. It's a rate visit per 1,000 people, but we used the same set of CPT codes. So we're comparing the same set of procedures, same set of services that folks are visiting for. So in-person visits were limited to only services that could have been performed via telehealth and do not include things like surgery, lab tests that require an in-person visit. So now we're going to jump into the demo. And getting to our webpage is very similar. So you're going to go to, can everybody still hear me? My volume is being wonky. Great. Thank you. My headphones are being weird. Let's navigate to this page. So the first thing you go to is that public data tab. Then you're going to go to focus areas, and then you're going to go to telehealth analyses. This is a plug for all the other telehealth data we have produced. Here you can see all of it, and then you're going to want to click on the telehealth equity analysis. The landing page, it has some important information about the report that we've covered a little bit, some high-level infographics, another demo that we've done previously, and then we have that use case. And then I'm going to cover understanding the report section, but if you ever forget this presentation and want to know better the instructions, we have them outlined for you. So yeah, now we're going to start. The first tab is going to be a map and table view. So the map allows you to select a geography and a service category or social factor of your choice and look at it geographically. And then the table is going to list all the county information together, and we will get to that later. And then the second tab looks a lot like the health equity interactive report, where it has those relationship graphics, and we'll dive deep into that in a minute. So let's start with that first tab, the map. So the first filter on the map allows you to select a county of interest, but you can also select all counties to see what's happening at the state. The second filter allows you to select any of the measures we've discussed, so you can see what's happening statewide. The default here is showing what's happening statewide and the telehealth visit rates for the whole state. There's a scale at the very top that's color in orange, and you can see how the different shades reflect in the map. So the darker orange counties are those that are seeing a higher rate of telehealth visits versus the lighter counties that have sort of lower telehealth visits. So let's play around with this a little bit, and let's select for our county El Paso. And then let's select percent of households without internet. Again, you get that weird warning, ignore it, move on, exit. Thanks. So you can see here, there's a lot of variation. The scale actually reflects that. You have some neighborhoods in this county that virtually have no households without internet access. And then you have other neighborhoods that are almost over a third don't have internet access. So this is really helpful because it shows you kind of the disparity that's happening in an individual county. Something else really interesting about this is if you hover over and select any of the neighborhoods, the census tracts, you can also see all the measures listed together. And then you can also see a race and ethnicity breakdown for the county and the neighborhood. So the green is going to be the county information, and the orange is going to be that neighborhood information. So a lot of information in the map. To reset it, you just click on that little home button and it'll take you back to the statewide. There it is, the whole state. So now let's scroll down to the table. So this section gives you a lot of options to really sort the data based on those measures. So if you're interested in ranking neighborhoods or counties to see, for example, the counties that have the lowest telehealth utilization, you can do that in here. The first filter is going to let you look at all the counties together. So you're looking at the whole state and then the second is going to be all neighborhoods. So you can look at all the census tracts together, or you can select a county and just look at the neighborhoods and the census tracts of that county. The second filter lets you sort the list by whatever measure you're interested in. So let's say you're interested in in-person utilization. You can select that and it'll change the table for you, voila. And then the third filter is going to let you sort it. So you can see low to high or high to low. That helps you kind of rank everything. There's also a statewide benchmark at the very, very top in that light orange that tells you what these percentages are for the whole state of Colorado as a kind of benchmark. So this is just another view, another way to slice and dice the data, but very interesting. And now we can go to that second tab. So again, this looks a lot like the Health Equity Interactive Report. We're using the R value, the correlation coefficient, to determine if there's any relationship between the rates of telehealth or in-person visits to any of the social factors that we've discussed. So there's two filters on this page. The first one lets you select a measure. So right now, the measure is percent people of color. And then another filter allows you to select the geography. So again, you can hit all counties, and that's going to give you the entire state, or you can select a specific county. So what you're seeing right now is the percent of people of color, and we've selected all counties. The first graph is going to be the telehealth visit rate. The second graph is going to be the in-person visit rate. So you can see the relationship of both. You can kind of compare. And every mini dot on this graph, I think it's a square actually, represents a neighborhood or a census tract. You can actually hover over the dot to see which neighborhood it is, so you can kind of identify the outliers. And then for both graphs, we have the R value outlined in orange. And if you hover over it, you'll actually see the scale and a statement indicating the relationship. So here it's 0.17. So this indicates a very weak relationship between those two measures. So the percent of people of color doesn't increase telehealth visits. That there's no relationship between those two measures. And you can see the same for in-person visits as well. So the same thing is happening below. So let's play around with this a bit and select the percent without a vehicle. And you can see here that the R values change, right? So we are at I think that's 0.35, and that indicates a moderately positive relationship. So there's a relationship we're seeing between households without vehicles and in higher rates of telehealth visits. Now, if you scroll down, you can see that there's a very weak to no relationship between households without vehicles and in-person visits. So again, really interesting. You can select a county to see what's happening at the county level. Denver, this is Alamosa. I was going to say Denver County. Carrie's driving. There we go. Thanks, Carrie. Denver County, you can see that this trend still holds the same, where we're getting a 0.41. So that's like a moderate, strong relationship again. So we're seeing a relationship between folks that don't have vehicles in their home and the higher utilization of telehealth. So very, very interesting. I do want to note that it's important to keep in mind that counties with less than 30 census tract, they have less data points. And so keep our results value, read them with some caution, because it is a smaller number of data points versus counties that have many more neighborhoods. So that's it. It's a lot of fun. I'm sure you're going to like hop off this call and go and play around with it. So we can get back into the presentation. So insights and findings. This is statewide. I'm going to run through this a little fast, but again, really important to note that there are multiple factors that can impact a person's ability to access telehealth services, including the ability of telehealth providers in their area, their network, personal preference, comfort level. Not everyone's comfortable with telehealth visits. So to fully understand what's happening with telehealth rates, communities really need to evaluate accessibility, community preference, barriers for each individual county, for each individual neighborhood. This data is meant to help folks ask questions and more closely into what's happening in their communities, but definitely not a lot of wide generalizations. So that being said, we can talk about statewide findings. We found that a lack of computers had a moderate relationship to telehealth visits, to lower telehealth visit rates. A lack of smartphones had a moderate relationship to lower telehealth visit rates. A lack of access to a vehicle had moderate relationship to higher telehealth visit rates. And veterans had a moderate relationship to lower telehealth visit rates. So factors that we think would impact telehealth, right? And some additional findings, most of the top 20 counties with the highest telehealth utilization were urban. You can kind of see that in the map. The darker counties are that darker blue, rural counties are the lighter blue. So compared to statewide, these counties have a lower percentage of individuals or households with people of color, without a vehicle, and with limited English. So those are kind of the social factors that we're seeing. And then for the next slide, we are looking at the lowest telehealth utilization, and those 20 counties were mostly rural with the exception of one. And those counties had higher percentages of individuals or households without a computer, without a smartphone, without internet access, and with disabilities. So again, important social factors, important places to dig into. And now this is just a plug for all of the public data that we have available to everyone. As public health practitioners, the community dashboard would be very interesting to you. The community dashboard is what we base the health equity analysis on. We also have a lot of information around the care that was provided during COVID-19. We have cost information, and we have drug information, and then we have a lot of consumer-facing tools, including Shop for Care. So you yourself are looking for healthcare and trying to find great value and great quality, you can definitely use the Shop for Care tool. That is our consumer-facing tool. So I think now we're ready for any questions you all may have. Oh, and this is where you can reach us, where you can find us.
Awesome. Thank you so much, Carrie and Claire, for this presentation. So at this time, we'll open it up for question and answers. I welcome anybody that has any questions to unmute themselves or drop them in the chat at this time. I guess I'll start it off with one question. How often is your dashboard updated? I know you're providing ED visit data. Is that in real time?
Claims data isn't real time, unfortunately, even though we get monthly claims. What we typically do for our public reports is we base them on a calendar year of data. So the next time we have a full calendar year of information, we will update it, because if we did it on a monthly basis, it wouldn't change that much. And it's a lot of effort and resources for us to produce these reports. For the equity analyses, we don't really have a regular schedule for updating those. We're going to just be evaluating it based on when we have more data available. The telehealth equity one was just released, or actually both of them were released last year. So they're fairly new, and we'll be looking to update them probably in the next couple of years. We don't anticipate the data would change that much year over year for something like this, though. A lot of our other reports we do on an annual basis regularly, like the Shop for Care tool is typically annual. The community dashboard, where we're actually looking at the ED measures, but we're not necessarily marrying them with the social factors, that one's updated every year too. So it just depends on the report.
Thanks. Also, what are the next steps following this analysis?
Well, both of these are brand new. This is our first foray into trying to pull in additional social factor data. So I think the next step for us would be to try and get feedback on how folks are using it, what would be valuable to see in the future. Are we looking at the right social factors? Because we honestly we had to pick some that we thought were going to be valuable. And so now that we know which ones actually have relationships, we might want to dig deeper into those. Maybe not look at some of the other ones. Like telehealth was hard because we had no idea what was going to be impactful. And really, we didn't see a lot of strong relationships between any of them. But we've already gotten feedback of well, why didn't you add percent income to that analysis? And that was something that OeHI, when we were working on determining what those measures were, they said, well, let's not look at that since you already looked at it in the health equity analysis. Let's not look at that. But now we realize we probably should have added that. So we're already starting to get the feedback from communities and stuff, and folks on this call, we would love to get feedback if people start using the information. That's probably our next step is to really do some community engagement around it and determine when we'll update it again and what additional healthcare measures we might include and what social factor information we might consider.
Yeah, and I'll just plug that you can also download all the data from the telehealth equity analysis, so you don't have to use the dashboard. If you want to manipulate the data and really get into it with Excel, you can definitely request to download the data, and we give that out for free as well. So through the link in the chat for all of our public reports, and you can find the links to both in that landing page.
Awesome, thank you. Are there any other questions in the room?
I think everyone's tired. It's a Friday afternoon. But we would love any feedback. Anybody who has questions or feedback, yeah, we would love that. And so please feel free to reach out to us at any point in time.
All right. Well, thank you for attending this session. And, thank you both for presenting such great information. I do have a few short announcements before everybody hops off. So slides and any additional handouts the speakers may have provided are available on Sketch. And as I'm sure many people that have been here from since yesterday have probably heard this message also, you will receive a conference evaluation form via email following the conference at the end of today. So please fill that out. Even if you've only attended a portion of the conference, it's really helpful for us and the planning committee in preparing for next year. And there will be a raffle for everyone who completes the survey within 2 weeks, where you could win one of two $50 gift cards. So there's some incentive there. I do want to also announce we'll have a 15-minute break, maybe a little bit more, before our next concurrent session, which begins at 1:30. And there are 2 sessions to choose from at that time. You could see that schedule on Sketch. So thank you everybody for attending this session. We'll see you soon.
Thank you.